In article 3C, 4C, 2C, we can able to read about RWMA in patients. Good evening all, this is Kavipriya, lecturer, Department of Cardiac Technology. Now the case study about a patient who is suffering from ischemic heart disease, and here we are explaining about how an echo play an important role to assess the ischemic heart disease for the patients in clinicals.
Ischemic heart disease is a condition in which there is reduced blood supply to the myocardium, most commonly due to atherosclerotic narrowing of the coronary arteries. This reduction in coronary perfusion leads to myocardial ischemia, which is prolonged, can result in irreversible myocardial injury or infarction. Echocardiography plays a crucial role in ischemic heart diseases because it allows non-invasive bedside evaluation of myocardial structure and function, helping not only in the diagnosis but also in risk stratification programs. Plays a crucial role in ischemic heart disease because it allows non-invasive bedside evaluation of myocardial structure and function, helping not only in diagnosis but also in risk factors, stratification and detection of complications.
So occlusion of coronary arteries will lead to ischemic heart disease will be detected by using echocardiography. If it is more sick patients or more bedridden patients will do for bedside echo, or normal patients or stable patients means evaluate patients means we can use normal echo to detect the which segments of LV get affected, which artery get occluded.
So I'll be presenting the patient's profile. So we present a case of a 58-year-old male who is a sedentary office worker presenting to the emergency department with acute chest pain. The patient had multiple cardiovascular risk factors which significantly increased the likelihood of ischemic heart disease. These included type 2 diabetes mellitus for 12 years, which accelerates the atherosclerosis, hypertension for 8 years leading to endothelial dysfunction, dyslipidemia contributing to plaque formation, chronic smoking history of 20 pack years causing coronary vasoconstriction and thrombosis. A positive family history of premature coronary artery disease was also present. The clustering of these risk factors place the patients in a high risk category for acute coronary diseases.
Yeah, well explained about patient profile. Here the causes for atherosclerosis are diabetic mellitus, major risks are diabetic mellitus, family history to hereditary, smoker, 20 years of continuous smoker, and dyslipidemia. Then hypertension also will be included. So next we can view about patient chief complaint. What are the symptoms are will be there to expose ischemic heart disease.
Now let's talk about chief complaints. The patient presented with severe retrosternal chest pain of approximately 2 hours duration. The pain was described as constriction-like and pressure type, radiating to the left arm and jaw, associated with profuse sweating, nausea, and shortness of breath. This associated autonomic symptoms strongly suggest a cardiac origin of chest pain.
So now we can go for history of patient illness. On detailed history, the patient was reported that over the past 2 months, he had experienced intermittent chest discomfort on exertion, such as while climbing, etc. These episodes were short-lasting and relieved by rest, suggestive of stable angina. So, however, the current episode differed significantly. It was more severe in intensity, longer in duration, not relieved by rest, etc. This change in pattern of chest pain indicates plaque instability with acute ischemia, pointing towards acute coronary syndrome.
So the scenario suggests for a stable angina because there is no decreased pain during the rest, and it is the pain duration for no loss longer. Okay. And the pain increases more during exercise after eating or taking rest at all. So it suggests a stable angina.
So going on for physical examination, on general examination, the patient appeared anxious, pale and diaphoric, which is commonly seen in acute ischemic states. So his vital signs were pulse rate was 96 beats per minute, which is regular, blood pressure 150 by 90 mmHg. Cardiovascular examinations, first and second heart sounds were audible, presence of an S3 gallop indicating left ventricular systolic dysfunction.
So S3 gallop, which is indicating LV systolic dysfunction, which is raised by increasing filling pressure of LV.
So in respiratory examination, So in respiratory examination,
Bimasal crepitation suggesting early pulmonary congestion due to LV dysfunction, and these findings maybe indicate ischemia has already begun to affect the LV performance, and also will increases the more pressure in LA side, okay, volume overload changes also. So we heard about